Welcome, everyone. Good evening. It looks like many are joining us and trickling in from all over the country, so welcome. We are going to get started as you continue to join us. It's so wonderful to have you here for today's webinar. We are going to host a presentation on ASCO 2021 and prostate cancer and early detection. This webinar is brought to you by Zero, the End of Prostate Cancer. My name is Shelby Monier. I'm the Vice President of Patient Programs and Education here at Zero, and I'll be your host today. I'm thrilled to be joined by our speaker, Dr. Tomasz Beer, for sharing his time and expertise with us today. So Dr. Beer, thanks so much for being here. I will introduce him shortly. First, I have just a few housekeeping items to cover, and then we'll get started. I want to mention that our webinar is being recorded today, and it will be posted on our website, zerocancer.org, tomorrow. And as soon as the webinar ends this evening, you'll receive a link to a survey. We would love for you to participate in that survey. We really value your feedback. We make changes and tweaks to our programming based on what you say about our programming. We want to do all that we can do to meet the needs of our patient and caregiver community. So please let us know what you think of the event. Tomorrow, you'll also receive an email with a link to the recording and the survey again. So for those of you not already familiar with Zero, we are the leading national nonprofit with a mission to end prostate cancer. Zero advances research, improves the lives of men and their families, and inspires action. So if you're new to the Zero community, we welcome you and we're thrilled that you found us. So a little bit about Zero's support programs and educational events. We're really proud to offer an extensive portfolio of patient support programs and educational events, educational tools and resources. All of these, of course, are offered at no cost to patients and their families. So if you or someone you know is in need of resources or assistance at any time during a prostate cancer journey, we would really love for you to share these resources and programs with them. It's really important that patients and their families know that they are not alone during this journey. So really quickly, I'll highlight just a few of Zero's patient support programs. First is Zero 360, that top left icon. This is our comprehensive patient support program. This is a patient navigation service, and it provides individual case management. And these are trained case managers, and our case managers help provide patients and their families with financial assistance opportunities. They help navigate insurance difficulties and also find other kinds of support, including emotional support and even transportation assistance in some states. Zero also offers some peer-to-peer support opportunities through our mentor and caregiver connector programs. This is sort of like a match.com program. We match patients and caregivers with someone who has been on a similar journey, and those individuals can receive and provide ongoing one-on-one support. Lastly, Zero Connect is our online private Facebook support group. And this is a group where you can really connect with others all over the country and even the world in some cases, and you'll get connected with those affected by prostate cancer. So here you can learn from others going through similar experiences, ask questions from patients and loved ones across the globe. Lastly, Zero's educational suite is full of informational sheets and one-pagers and questions to ask your doctor. We have patient toolkits, all of the latest and greatest in educational and website content in diagnosis and treatment information. We house a nationwide database of sites who offer free or low-cost prostate cancer screening. So be sure to check it out. We also have a full calendar of upcoming educational events. I want to highlight these two opportunities coming up. The next one, we are hosting a webinar for veterans on Tuesday, July 27th, and then our partners at Patient Empowerment Network are hosting a webinar coming up on Thursday, July 15th. Now I'm excited to get to Dr. Beer, today's leader of our webinar, who is going to provide us with a few exciting updates from the 2021 Annual ASCO Meeting that was held earlier this month. We'll then get to some questions from our audience. We'll do our best to get to as many questions as possible. So please type those into the Q&A box whenever you have a question, and we'll get to those as soon as we can at the end of the presentation. So now we're excited to get started with an introduction of Dr. Beer. So Dr. Beer is the professor of medicine in the Division of Hematology and Medical Oncology at the School of Medicine, and the Grover C. Bagby Endowed Chair of Prostate Cancer Research, and serves as the Deputy Director of the OHSU Night Cancer Institute. He's also the Chief Medical Officer for the Cancer Early Detection Advanced Research Center. Dr. Beer led a global randomized trial that demonstrated substantial improvements on progression-free survival, as well as the quality of life, which has served as the basis for a global change in the standard of care for advanced prostate cancer. So Dr. Beer is joining us from Oregon Health and Science University, and we are thrilled to have you here, Dr. Beer. Thank you.
Thank you so much for having me. It's such a pleasure to be here. I've been involved with Zero for many years now as a member of the Medical Advisory Board, and have had the pleasure of getting together through these kinds of seminars on a number of occasions, sometimes in person at the summit and sometimes through the computer. So it's really great to be with everybody today and be in some small way a contributor to this wonderful organization. What I'd like to do today is a little bit unusual. I'd like to essentially take you to ASCO and give you a firsthand look at a couple of presentations that I thought would be particularly interesting for this community. One of them is actually not directly prostate cancer related, but I know that the prostate cancer community cares deeply about cancer early detection. And there is some real progress being made in the early detection of cancer. And so we're going to be talking about initial results from the Pathfinder trial, which is a study of a novel blood-based multi-cancer early detection test. And then what's on everybody's mind in the world of prostate cancer, which was the presentation of a new radiopharmaceutical therapy called Lutetium-177 PSMA 617. These were data presented by Dr. Mike Morris on behalf of a group of investigators around the world. And this was one of the plenary presentations at ASCO, which is a setting where the four of the most important presentations in the entire meeting related to any cancer, not just prostate cancer, are selected for presentation out of about 5,000 abstracts that are submitted. So this was one of them, judged by the ASCO committee as an important advance. Mike was kind enough to share with me his slides, so I'll be taking you there as we look at the slides. Now, what I did here is I actually kept the science slides right from the meeting. I hope to make them a bit more accessible with the words that I choose to describe what we're seeing, but you're going to be seeing the same slides that were used in presenting these data. And let me start with the early detection study. So we all know about early detection in prostate cancer, and even in prostate cancer where we've had a PSA test for a long time, and in some ways we're ahead of many cancers with early detection, there are still significant challenges, as we all know. The PSA is far from perfect. It misses some cancers. It leads us down the garden path of false positive signals, not too infrequently, and sometimes leads us to diagnose very low-grade, malignant potential cancers that frankly may have been better off left undiscovered. So in prostate cancer, we have some significant challenges, but what's important for us to know, not just for ourselves, but for our loved ones and our friends, is that there are only 5 cancers for which there are any recommended screening tests, and that's breast cancer, colorectal cancer, cervical cancer, lung cancer in smokers, and prostate cancer. And that's it. And for the large majority of cancers, more than 300 different cancers, including some major dangerous cancers like pancreatic cancer, liver cancer, ovarian cancer, esophageal cancer, there are no screening tests at all. And so that's something that we need to address. Secondly, a big challenge in the field is the fact that so far we've approached early detection one cancer at a time. And so if one were, let's say, a woman, that woman would need to get a mammogram for breast cancer. If she were a smoker, qualify for a CAT scan for her lung cancer, get a stool test or a colonoscopy for colorectal cancer, and pap smears for cervical cancer. That's 4 different procedures, relatively involved, imaging involved, or examination in the physician office. That's completely unscalable to hundreds of cancers. We can't really have one test per cancer and respond to the need for 50 or 100 different cancers. Folks would be doing nothing but going to get their cancer screening test every 3 days to get through 100 on an annual basis. So what we need is something that is multi-cancer focused. The other challenge is obviously is that false positive results that suggest the presence of cancer when no cancer is present, lead to unnecessary evaluations, and those can involve invasive biopsies, so that's a big deal. Overdiagnosis, in other words, diagnosis of very low-grade cancers that aren't likely to progress, that may not need any treatment, and where they're diagnosed can lead to overtreatment, are a big challenge. And then access and actual execution on the screening plans is a big challenge. There's a lot of folks who don't get even the recommended screenings today due to lack of healthcare access, lack of resources, lack of knowledge. So there's a lot of challenges in the field that need to be addressed. And to this end, we and others have been working to develop blood-based cancer early detection tests. And these tests take advantage of the fact that cancers spill very small amounts of DNA or the code of life, if you will, into the bloodstream. And we now have DNA sequencing methods that are increasingly sensitive. It's like having a more and more powerful microscope, if you will, where we can now detect these tiny, tiny amounts of DNA in the blood. And if that DNA code reveals the presence of cancer, can use that potentially to detect cancers early. And that is exactly what the Pathfinder clinical trial examined in over 6,000 participants. So you're going to get a glimpse at very preliminary results of such a blood-based multi-cancer early detection test. I think it's likely to be part of the future of cancer early detection. I will say that so far, its sensitivity for early stage prostate cancer is not as good as for pancreatic cancer and other cancers. So this is not likely to imminently replace PSA testing, but it is the beginning, I think, of a different future for us. So this slide summarizes the design of the study that we did. This was the first study where such a blood-based test was actually used in people without cancer who were interested in cancer screening, where the results were actually returned to the patients and their physicians and used to look for cancer. So this was not a test of blood specimens collected from cancer patients and non-cancer patients. This was an actual live test of this approach in real humans who are interested in cancer screening. The primary objective was to see how complex the evaluation would be after a cancer signal positive result is returned, and to begin to evaluate the performance of that assay. How good is it at detecting cancer? How often does it yield true positive versus false positive, true negative versus false negative results? Adults over the age of 50 were enrolled at 7 US sites. A blood-based multi-cancer early detection test was ordered. Results were available within a couple of weeks. Signal detected patients then were evaluated for the presence of cancer, and all patients are being currently followed for a year, regardless of their initial signal detected cancer result. And this is the initial results in the next couple of slides. So we and our 6 partner sites were able to enroll 6,600 participants into this study. We found that 92 of them, or 1.4%, had a cancer signal detected. So this is a good result because we see 98.6% of patients get a no cancer signal detected result, and we're not triggering a whole lot of scans and biopsies and so forth for many patients who don't have cancer. So far, it looks like about half of the folks who get a signal positive result, we've been able to find a cancer. So it's not everyone, and you wouldn't expect everyone from a screening test, but about half of them turn out to be true positive, and in half the folks, we've not found a cancer, and we're currently considering them to be false positive, although we're continuing to follow patients to see if a cancer reveals itself. There's a lot of data on this slide, and I'm gonna just call your attention to a couple of key findings. So on the right-hand column here, I hope you can see my pointer. There's 6,629 patients. 92 have a signal positive, and the positive predictive value was 44.6%. So that's a calculation of if you had a positive test, what's the likelihood that you have a cancer? And it's all about 50-50, 44.6% so far. But the other exciting part of this test is that it doesn't just say we need to go look for a cancer. It's able to look at the DNA data and pinpoint pretty accurately where the likely source of the cancer is. And that's what we call cancer signal of origin prediction. And you can see that 85% of the time, the top choice that the test returns turns out to be correct. And if you look at the first or second choice, so what happens with this test is you get a cancer signal not detected or a cancer signal detected result. And if there's a cancer signal detected result, you get a prediction of where the cancer came from, the most likely and second most likely. So if you look at most likely or second most likely, those are correct taken together 96% of the time. So this blood test is able to pretty effectively tell us where we ought to be looking for the suspected cancer. And this gives you a real accounting of the actual patients that we found cancers in. And so the cancer types are on the left here. You can see the stages here. You can see that about half the patients with new cancers were early stage. About half had more advanced stages, with about a quarter unsuspected metastatic cancer. That's what you'd expect in an unscreened population for these cancers. But we were gratified to see that we were detecting the kinds of cancers that we don't have good screening tests for, things like liver cancer, head and neck cancer, lymphoma, pancreatic cancer, ovarian cancer. We did detect one advanced prostate cancer, but as I mentioned, prostate cancer at early stages does not spill a ton of DNA into the blood, and so we may need some other technologies to detect prostate cancer early with this approach. But I fully expect that this is just a first step, and we will be able to develop those kinds of technologies as well. So what we concluded from this initial analysis is that this MCED, multi-cancer early detection test, we call them MCEDs, was successfully administered and detected cancer signals in a broad range of cancers. More than half the cancers were early stage, and follow-up continues to determine outcomes at a year and learn if any of the folks develop a cancer that we weren't able to initially detect with the test. So I think what you're going to see fairly quickly over the next several years is that these types of tests are likely to become increasingly available. The company we worked with, Grail, is far from the only company that's working on this. And you'll see these kinds of studies, both for multi-cancer tests and for single cancer applications, like as a substitute for breast or colorectal cancer screening. And I'm pleased to be able to give you sort of an early glimpse of what's going on that's being reported at national meetings. Now we're going to switch gears and focus in on a new and exciting result for a treatment in prostate cancer. And here, let me start with a little bit of background. As you know, we think about advanced prostate cancer, and this is metastatic prostate cancer, as hormone responsive or hormone resistant. Some people call it castration resistant. I kind of prefer the term hormone resistant myself. And in the hormone resistant prostate cancer, we have several treatments available now. We have a couple different chemotherapies. We have a radiopharmaceutical called radium, and we've had potent hormonal agents like enzalutamide, abiraterone, and others. But the reality has been that some of our best agents we're finding offer an even larger advantage when used earlier in the course of the disease. And so many times now, we're adding these potent hormonal agents right up front with initial hormonal therapy. And when we do that, patients live longer overall. So it's a good idea. But when they get to the hormone resistant state, we actually have fewer treatment options. And so it is very good to see a completely different agent like lutetium PSMA 617 emerge as useful in this study. So a little bit of background. PSMA stands for prostate specific membrane antigen. It is a protein that is expressed on the surface of prostate cancer cells in the large majority of patients, not everyone, but a large majority of patients. It's being used for imaging and for therapy. And here is a schematic of how it's being used for therapy. Essentially, there's a molecule called PSMA 617, which is a small molecule designed to bind to this PSMA protein. Attached to it is a payload with Lutetium-177, which delivers lethal radiation to the prostate cancer cell after this molecule binds here and is taken into the cell. The radioactivity then causes DNA damage to the cancer cell specifically. The cancer cell is typically impaired in its ability to repair that DNA damage and goes on to die. And so this is an exciting strategy because it delivers the radioactivity to the cancer cell specifically, sparing most of the body, not all of it, but most of the body. It's a little bit like radium-223, if you've heard of that, but radium goes to the bones and is not specifically targeted to cancer. It cannot treat soft tissue metastases like lymph nodes, liver, or other organs. And it isn't really cancer specific, it goes to the bones. This is a cancer-directed way of delivering radiation. Busy slide here, but it summarizes the design of the study. So eligible patients here on the left-hand side were those with metastatic hormone-resistant prostate cancer who'd received at least one of the new potent hormonal agents like enzalutamide, apalutamide, darolutamide, or abiraterone, and at least one and potentially two chemotherapy regimens. So these were patients who were treated with a number of agents and were beginning to get to a place where fewer treatment options are available. The patients were randomly assigned to standard care therapy with or without the lutetium PSMA, with some restrictions. The standard therapy could not be radium or chemotherapy because those drugs had not been safely combined with lutetium, so we couldn't use those in this study. There are a lot of endpoints in this study, and this is how we design studies. I won't be showing you the results for all these. Some of these have not been reported yet, but the main endpoints were on the left, and that's something called radiographic progression-free survival. That means essentially time until the disease is able to progress as seen on imaging, not just by PSA. So new lesions on bone scans, or growth of lesions on CAT scans. And then of course, the ultimate endpoint, overall survival. These other endpoints will be reported in the future. They have to do with, and I have a couple of them in the slides here. They have to do with disease response, PSA, quality of life, and things of that nature, all important endpoints as well. The next few slides are going to show a lot of numbers. I don't need you to look at all those, just want to point out a few key things. They're shown here in blue for the lutetium PSMA, in yellow for standard of care, and then two different subsets of patients. Those that were analyzed for the progression endpoint, and all patients that were analyzed for overall survival. Bottom line, though, is that these folks were in their early 70s. They were mostly Caucasians. Many studies struggle with the accrual of a diverse group of patients. And I would, for those of you on the call who have any way to impact on that, I'd always try to encourage the participation of a broad and diverse group of patients in clinical trials. And we need to do that in order to be confident that the results that we report are applicable to everyone. Most of these patients had a good performance status, which means they were fit and up and around and relatively healthy. And then, the overwhelming majority had bone metastases. About half had lymph node metastases, and a smaller fraction had lung and liver involvement. So very advanced prostate cancer, as you'd expect from a study like this. Previous treatments included, as required, a prior high potency hormonal agent and a prior taxane. And some of the patients got more than one of these lines of treatment. So here's the main results. This is overall survival. This is how we present overall survival. These are so-called Kaplan-Meier curves. What you can see here is the percentage of patients alive on the vertical axis and time on the horizontal axis. So you start out at 100% and gradually the curves drop off, indicating the percentage of patients that are still with us. And you can see the curves separate very early on, within a couple of months, and stay clearly separated, indicating a 38% reduction in the risk of death at any given point in time over the span of these curves. We look at subsets of patients to see if there's any signal that suggests that the benefit observed with regard to survival was unique. So we looked at patients, depending on what they got on treatment, whether or not they had an elevated blood LDH, which is the prognostic marker, whether they had liver metastases, whether they were more or less fit, whether they were older or younger, and what race they were. And you can see that the benefit favored every group. The point estimate, or the dot, is on the left-hand side, favoring the experimental arm. The only exception to that was the Asian population, but this is a group where there were only 9 participants, so I would not read anything into that, there's no real reason why this should be different, but it does merit attention and points out why we need to be assertive and aggressive about enrolling a broad group of patients so that we can be confident. And I'm hopeful that this is just an artifact of a small sample size, but we'll need to see over time. This is progression-free survival. So this is disease control. And you can see the curves also separate and stay separate for the duration of the curves. The hazard ratio is 0.4. That indicates a 60% reduction in the risk of progression over time. You can see these curves are kind of bumpy, and that's because that's when the imaging is done. This is an imaging-based endpoint, and usually scans are done every 8 to 12 weeks on this study, and so every 8 to 12 weeks, we identify the next group of folks who exhibited progression. But clearly, progression was delayed with treatment. And again, this is the same sort of plot for progression-free survival, very similar results. The benefit is on the left, and is observed in every group of patients except this very small group of Asian participants, and we'll need to follow that up further. The investigators on this study also looked at what's called RECIST responses. This is a fancy medical term for tumor shrinking on a CAT scan. So this is not PSA, this is real CAT scan evidence of a tumor shrinkage. And you can see that in blue is the lutetium PSMA, and in yellow is standard of care. Here's complete response. So this is resolution of all visible cancer. We saw that in nearly 10% of the lutetium PSMA patients. Obviously, would very much like to see that be a higher number. But in these situations with folks who've been treated with multiple agents, that would be uncommon. And you can see that for the standard of care, nobody had a complete response. We see 42% of additional 42% of patients had a partial response, so a significant level of shrinkage of cancer, and another 35% had stabilization of disease. So, potent anti-tumor effect here, with only 13% of patients initially progressing. Obviously, eventually, these folks who respond, eventually many of them also progress. And in yellow, you see the standard of care, which does much, much worse in that regard. This is a so-called waterfall plot for PSA. And it looks like just solid color, but it's actually a whole bunch of lines, each one representing an individual patient. So when you see something like this, that's a PSA in an individual patient that went down by close to 100%. And this plot here is composed of the 333 patients that we have data on for PSA. And the majority of them had a PSA decline. This is the minority that had a PSA increase after starting therapy. And a 50% confirmed decline was seen in nearly half the patients. For standard of care, a minority of patients had a decline. There were some declines, but a confirmed 50% decline was only observed in 7% of patients. A pretty big difference with regard to PSA declines with therapy. There was a higher rate of drug-related adverse events with the lutetium compared to standard of care. And you can see that any treatment-related adverse event was seen in a large majority of patients compared to about a third of patients on standard of care. Part of this is because folks on the active treatment were on the treatment a lot longer because it was working. So there was more time on treatment. And of course, in that situation, one can observe more side effects. Part of it was obviously side effects of the treatment. Thankfully, serious side effects were quite uncommon at about 9%. And then this is a very detailed chart of the side effects. It's probably too busy to look at every number, but we did see more fatigue in the radiation arm than in the standard of care arm. And as we would predict, we saw more bone marrow suppression. So these are all fancy terms for low white blood cell count, anemia, and low platelet count. Dry mouth is a common side effect here, and this is because PSMA, although it's called prostate-specific membrane antigen, it's not 100% prostate-specific. It is unfortunately also expressed in the salivary glands. Salivary glands are where your saliva is made. They're typically in the cheeks. And you can cause some dryness of the mouth with this kind of therapy. And there's also some irritation of the gastrointestinal tract, resulting in some nausea and vomiting. But thankfully, severe nausea and vomiting is exceedingly uncommon at 1.5%, so about 1 in 70 patients. So the conclusions from the VISION study was that lutetium PSMA 617 can be safely combined with routine standards of care in patients with metastatic hormone-resistant prostate cancer and resulted in an extension of survival and delay in disease progression, was generally quite well tolerated. And we believe that these results warrant the adoption of this agent as an additional standard of care in advanced prostate cancer. We know that the FDA has granted this drug a breakthrough designation. I'm told that the company is filing in the very near future. It does take some time to get all of the data in the shape that the FDA requires, but I think they're very close. And the FDA has been approving prostate cancer drugs in recent times in about 3 or 4 months after filing. So I think many of us are quite hopeful that this drug will be generally available, certainly by the end of 2021 and perhaps a bit sooner. It's, we don't know, but that is what I would be guessing based on the prior timeline of approval of other prostate cancer drugs in recent years. So that's the end of my prepared presentation. I'm hopeful that we can have a conversation, that there are questions and about these presentations, and of course, anything else that's on your mind regarding prostate cancer.
Thank you, Dr. Beer. We do have a few questions. Let's just talk real quickly. One of them that came in from Michelle was about the lutetium protocol. And you addressed some of the side effects, the adverse events, but she's wondering if you could just address a bit more the associated quality of life experienced with the greater longevity with the protocol, or is it just that they live longer?
Yeah, so I can comment on that in a couple different ways. One is that there is formal quality of life data that has been collected in that study, and it's not been analyzed yet, but it should be. There's no reason behind it other than it's just a whole bunch of work and people are working on it, and we rushed to get these data put together. And by the way, I forgot to mention that the paper describing these results is now in the New England Journal of Medicine, so you can easily go and read the details of this. What I can tell you is that, having treated quite a number of patients with this drug as an investigator on this trial, generally speaking, it is genuinely pretty well tolerated. So quality of life tends to be good. I would view it as probably better than chemotherapy on average. And the main things that people really notice is those gastrointestinal issues and the dry mouth, both of which can be managed. I mean, they're obviously none of them are desirable, but for the gastrointestinal things, we do have pretty good countermeasures, and the dry mouth most of the time is mild, and one can address it with some hard candy and saliva stimulation. So, my personal experience has been pretty good, all things considered. There are no treatments, of course, for advanced cancer that don't have some side effects, and it's always a balancing act between side effects and benefits. But I'm pretty comfortable that in this case, the benefits outweigh the downsides.
Right, and I think that's a great point. Would you mind just speaking for a moment on really just the importance of reporting side effects to your treatment team so that they can be tackled together and ultimately, hopefully, leading to the patient being able to remain on treatment longer?
Yeah, absolutely. I mean, I think we talk with our folks about the fact that with medical treatments are not like surgery. If you surgeries, when it's necessary, it's wonderful. But I like to say that once you sign up for surgery, it's all in and you go under and then it's done. With these kinds of treatments, it's a journey, it's a process, and we start with a standard dose that is, we believe, the optimal dose for each patient, and then we're able to respond to any side effects. And so we definitely want to hear about them. There may be an opportunity to reduce the dose or adjust the dose or delay the dose or prescribe something that is effective at managing the side effect. So I would very much encourage folks to report side effects, not to be fearful that reporting them might lead the doctor to remove you from the therapy prematurely, or just, I don't know why one wouldn't, but I mean, I suppose some people don't want to bother their doctor, or think it's not important, or think they can tough it out, or and we definitely want to know about any new side effects, even if they're mild, and even if we just decide that there's nothing to do and we'll just live with those side effects. We still want to know, because sometimes they can develop into something more serious. We'd rather head them off early than late. So I completely agree with you with that comment.
Yeah, and not to beat a dead horse, but I think it really speaks to the importance of being sure that your treatment team has a great deal of experience treating prostate cancer. And I love this description that another oncologist used, that it's really part science, part art. And when you have more experience, and you know more people with various side effects, you're able to treat those a little bit better.
Yeah, I completely agree. I think there is, a focus on prostate cancer means that folks have, in-depth familiarity with the data and the new agents, and then experience counts. When you've treated thousands of patients, you've probably seen whatever ails you. You've seen it. Your doctors have seen it before, so
Right.
it's
Yeah.
helpful.
Yeah. Thank you. So we have another question. How many treatments and over what period of time did the patients in the lutetium arm of the study receive?
So how many doses of the treatment?
I think just how many were they previously treated, I think is what the question perhaps is asking.
Well, so the folks prior to entering the study, had to have at least what you'd consider 3 lines of treatment for advanced prostate cancer. Primary hormone therapy with something like Lupron or Zoladex and things like that. At least 1 high potency hormonal drug like enzalutamide, abiraterone, and similar, and at least 1 docetaxel, cabazitaxel type of chemotherapy. So these folks had gotten a lot of treatment. Once they came on the study, they got up to 6 doses of the lutetium. And so that was about a 6-month course of therapy. And in many cases, the folks that had a good response, that the cancer continued to be controlled even after the therapy was completed.
Thank you. Several questions coming in. Is there any reason why a person who is hormone resistant but who hasn't had chemo yet wouldn't benefit from from this possible new treatment?
So studies looking at this treatment in earlier disease states are being launched for sure. So we're going to have some data. I think that it's likely that if someone has advanced prostate cancer that's hormone resistant, they would benefit even if they've not received chemotherapy. I mean, there's no real reason to believe they wouldn't. I think the question is, what is the right sequence, and would they benefit any more? And would giving this treatment get in the way of giving chemotherapy later? One of the issues with radioactivity is it can do some damage to the bone marrow. We saw cytopenias, in other words, low blood counts. And, we don't yet know a lot about whether putting this in front of chemotherapy might reduce our ability to give chemotherapy later or not. So there's a lot to learn, but, I don't think it's absolutely required to have received chemotherapy before. It's just where we have most of the evidence today.
We actually have a couple of questions coming in, and I know that in cancer we generally want to steer away from the word cure. It's just not a comfortable term that we're used to using in oncology. But there are a couple of questions coming in that are ultimately asking, as the PSMA imaging testing is becoming more widely available to patients and these lesions are being found earlier, might this treatment have the potential at some point to be fully curative?
Yeah. So, I think that there's no question that in many cases, when you use an effective treatment earlier, it has a larger effect on the disease. We see that even with docetaxel, which, when it's chemotherapy, when it's used in hormone-resistant prostate cancer, it produces a modest survival advantage. When it's used in metastatic prostate cancer right up front, along with hormone therapy, the absolute survival advantage is 3 times longer than when it's used in hormone-resistant disease. So it is certainly possible that lutetium will yield a larger survival advantage. I think cure is a tall order because it's unlikely that every last cancer cell will express PSMA equally on its surface. And so I think the reality is that curing cancers historically has involved simultaneous use of multiple agents. If you think about how we cure testis cancer, it's a 3-drug regimen. Lymphoma, it's a 4-drug regimen. And I wouldn't be surprised if lutetium was a component of a multi-drug regimen, but to cure the disease, I think there's one of 2 strategies that have a chance of doing that. One is immunotherapy, and that has been tough in prostate cancer. It's not been as good as it has in melanoma or kidney cancer and other cancers. But immune therapy sometimes cures advanced cancers. And so that's where I would be looking. And the other is multi-drug regimens that essentially head off at the pass the cancer's ability to circumvent any single drug. And we're thinking hard about those kinds of approaches. Even though, as you said, cure is an uncomfortable word because we don't want to inappropriately raise hope that's not grounded in reality, I wouldn't hesitate to say that that's what we want to do. I mean, we're absolutely thinking about how to cure this disease.
Yeah, absolutely. I have a question about a Gleason score of 3+4 and choosing watch and wait, or I think watch and wait as opposed to active surveillance is what this individual is referring to. But how likely, just talk about the likelihood of becoming advanced in a typical timeline. I know that's a hard one to answer. It's, so individual. But if you could comment on that.
Yeah, well, I can comment in general terms, of course. Yes, just to provide a little bit of background for everybody, when prostate cancers are first diagnosed, there's a significant subset of them that are very small, very low grade, very slow moving, and where observation is the appropriate initial management. We typically call it active surveillance rather than watchful waiting. Active surveillance, the difference there is that the goal of active surveillance is to watch the cancer and treat it for cure if it starts misbehaving or growing, if you will. Watchful waiting is an older approach which historically didn't involve a plan for curative treatment, but rather watching until the disease spreads and treating it with hormone therapy. So most of the time today, we're thinking about active surveillance where we're watching the cancer with serial PSAs, perhaps repeat biopsies, perhaps MRI imaging of the prostate, and trying to detect any evidence that it's progressing. It's easy to recommend active surveillance when somebody has Gleason 3+3 cancer, which is the low-grade version, in 1 or 2 biopsy cores out of 12, suggesting a small low-grade cancer. 3+4 is a low-risk intermediate grade, and that is kind of the upper end of the range for which active surveillance may be appropriate. And so that becomes really an individual discussion with your physician. I'd be looking at the PSA level, at how many biopsy cores revealed cancer. Is there something visible on MRI? And if so, how large is it? And thinking carefully about the patient's age, the patient's health. And it ends up being a pretty complex decision. So it's not an easy one to just give a number, but there's certainly a literature for observing Gleason 3+4 cancer. One just has to be particularly thoughtful about that.
Right. I think your response just now kind of leads us nicely into another question that's partially about personalized medicine. But this person's wondering, are there blood or urine based tests, so opposed to genomic tests based on cancerous biopsy core samples, like Decipher, that can provide information on how aggressive someone's prostate cancer might be?
Yeah, so there are several tissue-based tests like Polaris, Oncotype DX, and Decipher, which have been used to predict some measures of aggressiveness in newly diagnosed prostate cancer primarily. Most of the studies there have looked at risk of recurrence after surgery. There's not a ton of data in active surveillance using these tests. And the reality is that quite often, not always, quite often, they confirm what we already suspect based on the PSA, the Gleason score, and the stage. I don't say they don't add in, they do add some information, but many times we kind of know what we're dealing with based on clinical variables. There are also, in advanced prostate cancer, there's a different set of tests. We can analyze tumors for tumor mutations, and those can suggest a course of treatment. There are drugs called PARP inhibitors, for example, that are particularly useful in people who have mutations in BRCA1 and BRCA2 genes in their tumor. There is another marker that in a very small percentage of patients reveals a likelihood of response to immune therapy. And there's likely to be more of those markers. So we do, in advanced prostate cancer, increasingly sequence the tumors. And we can do blood tests where we can either look for inherited abnormalities. So if we suspect that someone carries a prostate cancer predisposition gene, that can be tested in the blood or even in a swab from the mouth. Or in people with tumors where we can't get a biopsy easily, we can do blood tests and look for DNA mutations from the tumor in the blood. It's a little bit like those early detection tests I presented earlier, where we use the blood to analyze tumor DNA. So there's a lot of different molecular tests that are coming into use. Their utility is still in development, and I'd say that the enthusiasm with which they are sometimes presented is perhaps a bit ahead of their actual utility in most patients, but they're coming into use, and I think you're going to see more and more of them with time and more data.
Yeah. And we do have a question about the Pathfinder trial that just came in. This person is wondering, in the 92 patients who had a signal detected, what was the breakout between those at low and high risk based on clinical factors?
Yeah, so, most of those cancers, there was only one prostate cancer that we detected, and that was a patient with metastatic disease. So clearly high risk, not just high risk, but advanced. For most of the other cancers, we were detecting clinically significant cancers, colorectal cancers that were not subtle, esophageal, pancreatic, ovarian cancers. So at least the preliminary results would suggest that we were detecting clinically important and potentially aggressive cancers. We will continue to follow these patients, complete the evaluation of the remaining patients, and so there'll be more data forthcoming. But because the test relies on analysis of tumor DNA, the lowest grade, least invasive cancers spill the least DNA. So it's an advantage and a disadvantage in a way. I think we're going to miss some very small low-grade cancers because they don't spill much DNA, and you could view that as a disadvantage. But doing so will avoid some of the overdiagnosis problems that plague the PSA.
Mm-hmm. So we have a question that came in regarding the Lutetium study. Really just kind of wondering if you can explain a little bit how it relates to radiation therapy, or is it strictly just second line, or can it be used concurrently?
Yeah. So there's a whole bunch of different ways to deliver radiation to treat prostate cancer. The way radiation kills cancer is all the same. It's damaging the DNA in the cancer cells, but how you deliver it makes a big difference. So, first of all, there's radiation to the prostate with intent of cure, and that can be done with an external beam from the outside of the body, that can be done with proton, that can be done with implantable seeds or brachytherapy. Then there is external beam radiation to distant sites, which can be used to relieve pain or sometimes to try to control the cancer if there's very limited metastases. And then there is infusional radiation, which goes all over the body through the bloodstream and either goes to the bones like radium or to the tumor like lutetium PSMA. Inherently, there's no real reason why lutetium couldn't be done concurrently with external beam radiation, at least to metastatic sites. I think it's unlikely it would be done concurrently with radiation to the prostate, because there the doses of radiation are really pushing the limit of toxicity, and I think that'd be a concern about overlapping toxicities. But in somebody with metastatic cancer who needs a bone lesion radiated for pain relief, there's no real reason why they couldn't get lutetium PSMA at the same time. But we'll have more studies and we'll look at that more closely.
Great, and we think we have time for this last question before we say good evening. So just another follow-up to the lutetium, since it's being shown to be really effective and it's so exciting. Are there any other agents in the pipeline that are perhaps going to allow even a better quality of life or longer progression-free survival?
Yeah. So there are a lot of agents in the pipeline. I mean, it's crazy out there trying to keep up with everything that's going on. But relevant to this, I would say a few things. First of all, in terms of radiopharmaceuticals, there are two directions that are being taken. One is targeting PSMA with other radioactive molecules. There's a study involving a radioactive molecule called curium, and it may have some difference or some advantage, we'll see, over lutetium. The other is to take lutetium and attach it to something different and target other proteins on the cell surface of prostate cancer. So there is early stage studies, phase 1 studies of lutetium attached to something that's not 617, but some other molecule that is present in some people with prostate cancer. And to me, that's hopeful, because that can potentially be used in combination with those goals of more profound responses. The other thing that's going on is that because PSMA has been so interesting, it's also a target for immune therapy. And so one of the studies that we have going on right now at our center is of something called a bispecific antibody, or a BiTE therapy, where an engineered, a custom designed antibody has two arms. One attaches to PSMA on the prostate cancer, the other attaches to a T cell, and essentially brings a killer T cell directly in contact with prostate cancer and induces it to use immune mechanisms to kill the cancer instead of a radioactive molecule. So a lot of activity there. Amgen has a drug, a company called Harpoon has a drug there. Regeneron, which folks have heard of since the pandemic, has a couple of drugs there. So a lot of activity in related areas, but a lot of those things are in phase 1 and phase 2 studies. So this is the one that's going to come first if the FDA agrees.
Yeah, very exciting. Well, thank you. With that, Dr. Beer, I want to just thank you so much for your time and expertise. And I'm sure you were very sad not to attend ASCO in person this year and then have to do it all virtually. But we really appreciate you bringing all of the insight that was shared at ASCO to our patient and caregiver community tonight.
I really appreciate the chance to visit with you today and everybody's attention and time.
Yeah, thank you so much, Dr. Beer. So to our attendees, thank you for participating and listening in on our webinar this evening. And to close our webinar out, I just want to make sure that you're reminded that Zero is here. We are here to support you. All of our programs are here for you. We want to learn more about what you need. So be sure to fill out the survey and our evaluation at the end of the program. Listen back. I know the slides were really wonderful and scientific, so I'm sure that rewatching is going to give you even more insight into ASCO 2021 and to Dr. Beer's amazing presentation. I want to thank you again for joining us and spending your evening with us, and good night.